as a pediatric oncologist, I really encourage families to get a second opinion, for even when they come to see me. And you know, if you get two opinions and those two physicians can work together, you'll have a better outcome. For those of you who don't know, MEN is multiple endocrine neoplasia. If you have a mutation in the menin gene, then you are more susceptible to have a neuroendocrine tumor. Let me ask answer John's question about surgery in a more general way, in terms of surgery for children with neuroendocrine tumors versus surgery for adults with neuroendocrine tumors. And I would say we're more aggressive in children. My philosophy, and I think the philosophy of my colleagues now on the multidisciplinary tumor board, is that the more disease you can get out, especially if you're going to use peptide receptor radiotherapy, or PRRT, the more you can get out before you start the therapy, the more effective the therapy can be for that tumor that's left. And, you know, if you think about it and you have a big chunk in the liver, then a lot of your PRRT is going to go straight for that big sink. And if you could get rid of that before you start the therapy, then there's more left to go to the other smaller sites. So we're very aggressive in terms of removing as much as we can surgically before we start therapy, whether it's chemotherapy or PRRT. In terms of whether children with MEN would have surgery earlier, actually, our group here uses very specific monitoring, and the specific mutation that you have in the gene can also give a hint as to when surgery is advised. As you know, we now take out the complete parathyroids, or we may take them all out but reimplant a small piece of one. And similarly, when we do thyroid surgery in children, we can take out part of it. But we are very good at monitoring hypercalcemia, and actually the hypercalcemia can contribute to the insulin problem as well, and because it helps release insulin. So we use those biochemical markers and follow them very closely to help us determine when to do surgery. Rasima, this is a very important question. And I can tell you that one of the reasons that I follow kids is because most of the appendiceal operations now are minimally invasive surgery. And the good thing about them is how quickly we return to life without having post-surgical symptoms. But the one negative is that it's very difficult to look for lymph nodes. So with that kind of surgery, so I follow with the neuropeptides, because we have very well characterized which neuropeptides are in the appendix. And so I think for any of you out there who are, who have a child with an appendiceal tumor, you should obtain the pathology report and keep that with you. I mean, you should have a good record of it. Know what the Ki-67 is, or the grade of the tumor, whether the pathology report said it was grade 1 or grade 2. know what the surgical report says in terms, and the pathology report say, in terms of, was there, they'll say, lympho neuro invasion. They may say, but they also need to say, what were the margins all clear? And if your pathology report does not say that, then you should ask the surgeon to help you find out that information and get that clarified. So that pathology report is extremely important, and that is really what determines mostly how much you need to be followed. Now, we were talking earlier about CT scans, and one of the things you can do is, but we don't normally do this, is have a CT of the abdomen after the surgery is done, or actually it can be before, and go back and look at that CAT scan and see, was anything reported about lymph nodes? They would say lymph nodes in the abdomen, and that's important for you to know as well. So, one of the things about going to a specialist is that these are questions you could ask the specialist, and they would, if they didn't have the answers, they would know how to get that answer for you. So there's a lot of information in the pathology report and in the surgery report that you should keep track of, and that will help either your pediatrician, or if you go to a specialist in children's neuroendocrine tumors, they will help you figure that out. That's a tough question to answer. And I don't remember that I've ever seen a child who had 2 nets in the appendix. If they generally, tumors in the appendix are grade 1 or grade 2. I've never seen a grade 3 neuroendocrine tumor. And this grading is done based on how many cells in that appendiceal tumor are actually in the process of dividing. And I'm sure most of you are familiar with the Ki-67. So we grade it by the number of Ki-67 positive cells in the tumor. I have seen grade 2 appendiceal tumors, but not grade 3. And so 1 is the grade of appendiceal tumors. The second thing is where they've invaded. Have they invaded outside the appendix? That's really the key point. My own personal way of following these children, it is to follow them with neuropeptides as well as with scans. So if I had a child who had an appendiceal tumor that was completely contained and completely removed, I would not do a gallium PET scan. I would simply follow the chromogranin A and the pancreastatin and the neurokinin A. I usually follow them every 6 months for 3 to 5 years. And if those are normal that whole time, then it's very likely. The actual literature out there have been 2 large studies, one at the Mayo Clinic and one at the University of Minnesota, and a smaller study at St. Jude's. All of these studies show that the incidence of a child with an appendiceal tumor having any consequences is less than 1%. So it's, and especially if you have, again, what I said was, if the tumor is completely enclosed in the appendix, then it's a very low risk. And I think following every 6 months to a year for up to 3 years is sufficient. In fact, there are some of my colleagues out there who would say don't follow anybody at all. I think it's important. I think the youngest I've had with an appendiceal tumor is about 10. And I start telling these children, you are going to need to remember that you had this, so that when you get to be an adult, you make sure that that's in your family history when you report your own family history. And I think that's the important thing. 20 years ago, when we took out an appendix, we didn't even do a pathology report on it. We don't have a whole long experience, but I think we have maybe a 50-year experience by now. And again, the incidence of a child with a neuroendocrine tumor of the appendix having long-term consequences is way less than 1%.
So
that's not true in adults, I should say. So if you're 18, 19, 20, or 30 and you have an appendiceal tumor, you need to be followed much more closely.